Okay, any last questions? We're gonna, Dr. O'Shea, you'll want to go on mute until it's time to speak.
Okay.
Everyone else is on mute.
Fine. Mute.
It's 10:58. You're good because you don't have audio. You're sharing this one.
Oh, okay.
So you are good. All right, ready? Nope, you're good. Oh, actually, what you can do with that, to get out of the way, is this. Sometimes it'll pop back up.
Okay.
You might just have to click that.
Okay.
And if push comes to shove, you can say, hey, Chris, I'm having a problem with,
Okay.
rather than trying to point to it, because I won't know what
Okay.
you're talking about. And our attendees will be patient. All right, I'm going to go ahead and go live.
The broadcast is now starting. All attendees are in listen-only mode.
Thank you for joining us today. The webinar will begin at the top of the hour. The webinar will begin in one moment. Thank you. Thank you for joining us today and welcome to the webinar. This is the 2016 Health Catalyst webinar series. As a quick introduction, Health Catalyst is an outcomes improvement company focusing on healthcare data warehousing and analytics. My name is Chris Keller and I will be your moderator today. Our webinars are intended to be educational opportunities to explore the many facets of healthcare transformation, culminating in our annual Healthcare Analytics Summit this September 6th through the 8th in Salt Lake City. Those of you who attended our webinars in the past couple of years may remember that we held summit registration giveaways at the end of some webinars leading up to the summit. We will be doing that again today. Now let us begin with today's webinar, Making Sense of the New MACRA Announcement, presented by Bobbi Brown, Vice President, Financial Engagements, with commentary from Dr. Brian Oshiro, Chief Medical Officer at Health Catalyst. Throughout our presentation today, we encourage you to interact with our presenter by typing in questions and comments using the questions pane in your control panel. We will be answering questions at the end of the presentation during our questions and answers time. We are recording today's session, and shortly after the event, you will receive an email with links to the recorded on-demand webinar, the presentation slides with the poll results, and the names of the summit giveaway winners. We will be providing a transcript of this webinar and will send out a notification once this is available. Also, you can follow us on Twitter. Our handle is @HealthCatalyst. Before I turn the time over to Bobbi, we have 2 poll questions. Let me go ahead and load that first poll question right now. What is your primary functional area of expertise? We have 5 options: clinical, finance, IT, executive, or other. We'll give people a few moments to answer that question. Very good. We'll close that poll question. Share the results. All right, we've got a nice mix of people today. Fewer in finance than typical. 21% clinical, 8% finance, 19% IT, 25% executive, 27% other. Thank you. Now on to our second poll question that pertains to today's topic. How ready are you to participate in MACRA? 5 options: not at all, somewhat, unsure, ready, very ready. We'll give you a few more moments to answer that question. Very good. We've got great response here. Okay, we'll go ahead and close that poll and share the results. What do you think about that, Bobbi?
Wow, a lot, and we can see a lot in the unsure category. We do have a couple people, 1% are very ready, so that's great. Hopefully they can share some feedback with us today as we're going through this. And the not at all, that I'm glad you're here. That's why we're here, to try to help out in the somewhat category. We'll get you there. So
very good. Thank you, Bobbi. We'll go ahead and turn the time over to you now to present.
Okay, Making Sense of MACRA. It's a great day here in Salt Lake. We have this cute little boy up on the screen. He's ready to take on anything, just like we're ready to take on MACRA. So the first thing that happened, I think it came out maybe 2 weeks ago, the regulation, the proposed regulation came out. And I don't know. I wish I could ask a poll of how many people read the 962 pages of regulations. I hope not a lot of you. It's an interesting scenario. People, when I've been in this business a while, as you can probably tell if you read the write-up about this webinar, and we used to have a fight between some partners at Ernst and some partners at Arthur Andersen to try to see who could get the Federal Register the fastest and read it and then interpret it and get it back out to our clients quickly. We don't have to do that anymore. It's all online, which means you can stay up all night and just dial in and look at them. But I'm a pretty calm person, and I've been pretty calm through all this. And I have to say, I went through the regs once, and then I had to go away and come back. So the coming back is what you're going to see as I went through and figured out what's going on. The whole point of this, it was House of Representatives Bill 02. It was passed last year in April of 2015. And it was, and I want to come back to these at the end. They want to offer multiple pathways for risk and reward. They want to minimize reporting burdens and streamline multiple programs, and then reward clinicians for value over volume. That, as anyone will tell you when they read these are great. The devil is in the details. So let's talk a little bit about those details. At first, when you read this, you kind of think, what is this? And you're never sure whether to say MACRA or MACRA or SGR or MIPS or how to say it. We kind of develop our own little language around this. But MACRA is the Medicare Access and Chip Reauthorization Act of 2015. It did pass for another 2 years the Children's Health Act, which is always great, but we're not going to focus on that. The Sustainable Growth Rate is what got replaced by MACRA. And MIPS is a merit-based incentive payment system. APM is alternative payment models, and they snuck a little something in on us in this. There are alternative payment models, and then there are advanced alternative payment models, which we're going to talk about. And the eligible professional became the eligible clinician. So if you were an EP, you're an EC now. So again, overall goals for CMS, I think it's just great that they put these out there last year. They said by 2018, we want to be 90% based on quality, and we want to have 50% based on alternative payment. Right now, just in context, 22% of the payments that Medicare makes go to physicians. So that's the segment that we're talking about, and they're talking about overall on the slide on the right. But now we're going to be focused on this 22% of payments, approximately $138 billion a year. And of course, Medicare wants to get the private sector commercials to match this. And I don't know if too many commercial payers will get in and have this level of regulation around it. But there are some things that they can do, definitely tying to quality using some of the same metrics, which would be wonderful, and see where we go from there. Again, these goals, can't argue with these. We want better care, smarter spending, and healthier people. And they're going to do that via incentives, the care delivery, and the information sharing. The reactions. I'm going to let Dr. Oshiro speak a little bit about this like I said, it was kind of a frenzy when this stuff first comes out. And what do we think about it? And I've put some up on the board and let Dr. Oshiro.
Yes, thank you, Bobbi. You know, it's quite interesting when you go and talk to physicians. I've talked to many of them, and they really don't understand what the actual changes are. There's a misunderstanding that because of the new MACRA laws and the payment schedules and so forth that are proposed to be changed, that they thought that meaningful use even was going away. So there is a lot of confusion. But for the most part, it's interesting to me that although Stephen Stack, the president of AMA, says this is the most profound change to physician compensation in more than 25 years, and there's going to be a lot of anger and frustration, I think a lot of that stems from the fact that people just don't understand it, and they're really not paying that much attention to it. So it's just quite an interesting environment in which we live.
Okay. So just a few, trying to make it simple. And this one, I want you to think about feedback mechanisms are too far removed from the performance year. Let's come back to that one. The performance year, it's 2017. And guess what? How many months away is that? 7 months away, and we're going to start into a performance year. So, one thing that potentially could happen with your feedback, and particularly with this being an election year, is maybe some delays. Maybe it won't start January 1st. I don't know. We should take a poll on that and see when it's going to actually start. But again, if I get across anything today, 2017 is around the corner, and that's when the performance year is going to be. You don't get paid this way until 2019, so you tend to think, I can go to sleep for a while. No, you can't, because the performance year is going to be 2017. Some additional aspects of this, CMS has agreed to give $20 million a year, technical assistance for small practices, and they put in $75 million to have physician groups get together to improve the quality of measurement development, which is good. Both of those are good things. We'll have to figure out how to tap into them. Okay, there's a million different charts out there, and I need to say CMS, if you just go cms.gov and type in MACRA, there's really good information out there. They're doing really good webinars. It tends to be a lot of repetition of regulations themselves, which I used to love to do, just sit there and say 4%, 5%, 7%. But so you need that piece of it, and then you also need the piece of what you're going to do with all this. So again, there's 2 tracks in MACRA, MIPS or the APM for qualified providers, and if you go into the MIPS track, which is where you don't really get to choose. Medicare is going to put you probably in MIPS, and we'll talk about which track and how you get into the different tracks. And then again, I mentioned the performance year is 2017. Then starting 2019 for MIPS, your payment can go up or down by 4%, 5%, 7%, 9%. Then it stays at 9%. And you can either be plus or minus those numbers. You can be neutral, get nothing, increase on your fee schedule, and then there's also potential for a bonus, which we'll go into. So they did actually give out regulations past this date, but to me it was just too much. I thought, well, who cares in 2026 if I'm going to get 0.75003% increase? I want to focus on today. So I didn't even put those in there. On the value-based side, 5% bonus. And at first I was thinking, everybody go into the value-based side, but it's not going to be as easy to end up in that track. So, and there is some crossover between the tracks. If you're in the MIPS and you're also in an alternative payment program, some of those things you'll receive credit for some of those things. If you fall short, if you're in an advanced payment and you fall short, you can still get the MIPS payment, and they've tried to align the quality payment program between the two so that the measurements are the same. Okay, important part, proposed rulemaking. The public commentary, we have from now until June to give our commentary, and then the final regs will be published in, again, November 2016. And that's not a lot of time period until January, from November to January. So again, we'll have another frantic reading of all those regulations when the finals come out. I gave you the web address here to submit any comments that you may have to CMS. They are really listening to people and trying to take into account everybody's feedback. The reporting period will be once a year. And you're only going to see your results once a year. So hence that comment that was made earlier. The first feedback period will be July 2017, which will be data from previous 2 years. Your second feedback report will be in July of 2018, which will be on the actual data. And just to remember, all this data is going to be made public, and it's going to be on Physician Compare. When Medicare first started putting all this data out there, I was working at a system, and my boss said, and I'm a finance person, and my boss obviously was a finance person, but he said, get out there and find out everything that's on the web about us, because I don't like this. So, and make sure that the data is correct. So you will want to be thinking along the same way. You want to make sure that reports that Medicare sends you, you look at them, because they are going to be made public. Okay, let's talk about these two tracks now. We have this MIPS, merit-based incentive payment system. I have to say I like MIPS. I like saying that. This will be the default. And who's eligible for this? In years 1 and 2, it's physicians, physician assistants, nurse practitioners, the clinical nurse, and the CRNA. And then they are proposing an expansion in year 3. So for additional PT, OT, and social workers and the nurse midwives. So,
Bobbi, let me insert a question that an audience member asked, which is, what does base year mean?
Base year, in this, did I use it? Base year will be 2017 generally. So that will be, and I'm using, sometimes I'm changing the word base year and performance year, and I really shouldn't. It really is the performance year, which is 2017, because in the other program, there's also a base year of payment to be based on 2018. So it is generally 2017, and I'll try not to use the word base and performance year.
The other, I think you're going to talk about exceptions, but there is an exception for low volume providers that don't charge more than $10,000 and provide care for less than 100 Medicare patients in a certain in 1 year. So they do have that provision there too.
Yes, on the screen right now we have exception for MIPS. If it's your first year of Medicare participation, you will not be, and then this low volume threshold that Dr. Oshiro talked about. So 100 patients or $10,000, and then if you are participating in the Advanced APM, you won't be in MIPS. But it has to be the Advanced APM, not just APM Advanced. Okay, so when you're in MIPS, there's a composite score, and it's weighted. And that's probably the most important thing you need to know. I'm going to drone on about a few more things, but it's quality, cost. This is a new one, clinical practice improvement activities, and advancing care information, which is the old meaningful use. And then the weights are over there. And these do change by year. Eventually, cost goes up higher and quality goes down lower. And the other two seem to stay constant over the time period. So if we talk about quality, the quality metrics were, if you're used to PQRS, you're used to submitting, was 9 measures with a domain. Now it's down to 6 measures. And they are giving you a selection of over 300 measures, and they're actually in the last 200 pages of the regulation if you want to look at them. You do have to have one cross-cutting measure and one outcome measure. Example of a cross-cutting means that it impacts a lot of different practices. So a care plan, do I have a care plan? An outcome measure, again, CMS actually defines what's a process measure and an outcome measure. So for an outcome measure, in this case, is cataracts. After cataract surgery, I have better visual acuity within 90 days. So again, this is going to be weighted 50%. The stakeholders that they went to, they talked to 6,000 people. And there is what they called a measurement document out there. It's 80 pages long. So if you like documents, this is not as long as the regulation, but it does give you their basis for how they developed some of these measures and who they talked to and what their criteria were. And just talking about criteria, I think it's interesting to always start out with what were they trying to do, trying to have outcome measures, as I mentioned, trying to have, and the safety measure, I can't imagine we're not going to see more on opiates, just everything that's in the news to important drug classes, safety related to important drug classes, care coordination, telehealth, proms. No, you're not going to the prom, but those are patient-reported outcome measures. I personally was sick last couple years ago. I actually had sepsis, And I had to go back to my doctor, and they gave me a little a laptop, a little iPad, and made me fill out, how I was doing. And I thought, oh, this is the stupidest thing in the world. And I could tell a lot of patients in the waiting room were having a lot of difficulty doing this. But my friend, who's a nurse, she said, no, that's extremely important. Your patient reported outcomes, how far you can walk, if you can pick up your shopping bag, that's extremely important to her to know, and make sure that, that I'm making improvement in those areas. So it was more important than what I realized. So I'm learning something new every day. Affordable care, where are we overusing areas? High imaging, are we overusing anything? And finally, our population, we know we want to really get into population detection and preventing chronic disease. So again, all of these things went into the quality metrics and which ones they picked. So the resource, this is the cost one. It's just weighted 10% this year, and they're going to compare resources used to treat similar care episodes and clinical conditions across practices. They will risk adjust, and they will calculate this number for you. And I don't know if that's a good thing or bad thing if you like somebody calculate numbers for you. But they have the information from claims, and they will calculate it for you. Right now, there's a thing called the Medicare spend per beneficiary, another acronym, MSPB. And it is public information. You can get it right now for all the hospitals, and it shows you, what they're looking at, and looking at 3 days prior, the hospital, and then 30 days out, and they could change any of these, and looking at your hospital compared to your state, compared to your nation. So the data is there. They're going to start, they also want to start doing it by conditions, like for congenital heart failure, for COPD. So they are, part of this regulation had some groupers in it of how they might potentially group 40 to 50 different conditions. So that's coming down the pike. That's going to be part of the piece on the resource use. The clinical practice improvement activity, CPIA, I like that, those little initials, it's 15%. It's not a lot of detail, but they do have 90 plus activities, things like expanded practice hour or expanded patient access. So for things like, do you have weekend hours? Do you have hours at night? Do you have 24-hour hour access? For the care coordination, have you implemented practices that document this care coordination? The beneficiary engagement, we talked about tools where the beneficiary is involved. Obviously, patient safety. There are different programs you can participate in that will count as this. You only have to pick one. What I couldn't find out from the regs is how long you have to do it. It looked like they were proposing that you do it at least 90 days, but hopefully in the final regulation that will come out, and we'll see how long we have to do some of these things. But again, all of these are things that are beneficial to the patient and the beneficiary. The final advancing care information, weighted 25%. This is what used to be called meaningful use, or MU. So you're going to have to use a certified EHR in your practice. There's going to be emphasis on interoperability and information exchange. And there's not any more quarterly reporting, and it's not an all or nothing. And they took out the COPE and clinical decision support. So in the beginning of the year, we had a lot of flurry because the acting administrator, CMS, Andy Slavitt, wrote, meaningful use that has existed will be effectively over and replaced with something better. So, and he, it was a great tweet. I think we all got excited. It's not over. We still are going to be reporting measures. But the focus is towards the use of technology and the outcomes they're going to give our patients. So again, what criteria are we looking at in this advancing care information, protection of the information, patient having electronic access, the electronic prescribing, coordination of care, and information exchange, and public health and clinical data registry. They eased back on some of these registry requirements and some of the public health as you go through the regulations. What are you going to have to do starting in January of 2017? Again, this certified EFR, report 8 if you're in stage 2 or 6 in stage 3. And you're going to have to attest that you've cooperated with surveillance and that you've cooperated with health information exchange and information blocking. So, okay, now all of these go together. The quality, the cost, the clinical practice improvement, and the advancing care, and you get points, and then you get scored on each one. And the advancing care is interesting because there's 60 points for this, the performance is 10 points, and a bonus score. I put all this up here just to let you know it's a little complicated. It's not going to be something that we're going to be able to do in 3 seconds. Then they take all these measures and convert them to points, and they are going to let you know in advance what the targets are going to be, which is good. So we're going to know ahead of time. So if I want to be in that top performance, I know what I have to do. You can also submit, these measures can be done as a group. And that's an interesting one because consumers want to know about individual physicians. Individual physicians want to report as a group. So it's just an interesting dichotomy that we have there. And again, this MIPS, we're going to have those 4 areas on a 0 to 100% scale and put them together, and you'll get a score for each one and come up with, of course, a CPS. So in case you hear CPS, that's your composite performance score for all of those 4 areas. And in the first 5 years, there's going to be 100 million extra each year, or 500 million over the 5 years as an additional performance bonus that's exempt from budget neutrality for exceptional performance. So if you really are an exceptional performer, you can really get some extra money in here. Okay, so when we boil this all down, they're going to adjust the payment then based on that score. It is a budget neutral program, so whoever goes below, then that can go to the people that are above. And what I put on there, the 46% is what CMS is put in the regulation as what they think the number of people that are going to be below. And the interesting thing is that really varies by practice size. For the small practice size, it was up to 80% that they thought were going to receive a negative adjustment. For overall practices, all sizes, it's 46%. And then obviously the inverse of that is 54%, saying that that will be performance above. And you can either be neutral or performance above, and you have a potential for a bonus that won't exceed 10%. And they're also going to do some scaling in this. So they're not going to scale on the downside. And remember, I said the first year it's plus or minus 4%. And if they do some scaling, if there's a lot of people below, if their number isn't right and it's more people below, then they're actually going to let the people above earn more money to make it budget neutral. So what goes out will be, like I said, a zero-sum game. So interesting. Good way we can forecast. Okay, the other track is the alternative payment model. Okay. Really, this is where the alternative payment model, as you saw in the beginning, is where CMS wants us to go as an industry, and the Congress wants us to go there. The current administration wants us to go to these alternative payment models, which are things like ACO, bundled payments. We have a couple of bundled payment models. So that's where they want us to go. Now, MACRA it's not for hospitals. It's only for physicians, and it doesn't change any of the existing programs that are out there. So if you're in an MSSP, ACO, nothing is changing there. Some of the quality measures that you're reporting will count towards MACRA, but generally there's no change in those programs. So there are, and as I mentioned, you have to not just be in an alternative payment model, you have to be in an advanced alternative payment model. And right now there are 5 different types of models that qualify for that advanced. And I put them up here, the ESRD, the Medicare Shared Savings Program, Track 2 and Track 3, not Track 1. So if you're in Track 1, you're probably still in MIPS. The next generation ACO model, 21 participants. The CPC model, which is right now just came out, this comprehensive primary care model, just came out, and right now Medicare is asking for payers to participate, and they're going to ask for your participation, I believe, starting in later in the, I believe it's going to be in about July, they're going to start asking. They're going to pick 20 regional areas in the country, and if you do participate in that, you will be considered an advanced APM. And then there's another model that's going to be available in 2018, which is the oncology care, which is a two-sided risk model. So what they're really looking for here, it's the risk that they're talking about. How much risk are you taking? And that will qualify you into an APM model. So advanced APM, how do I qualify? Payment has to be based on quality. I have to be using, at least 50% of my providers have to be using a certified EHR. And I have to bear financial risk, and the risk has to be at a certain magnitude. So and this changes again every year. The first year, I believe it's 30% risk. I can't have a stop loss that covers the risk. It has to be true risk, and they have 3 different formulas that you have to run through. And then they also have this medical home model, which is, again, several pages of regulation that you have to fill to be able to qualify. So therefore, it's going to be difficult to qualify for an advanced APM. So we can probably make some assumptions that a MIPS is going to be the big deal. Not only do you have to be part of an advanced APM, but you also need to be a qualified provider. So, and this part is done. Another test you have to go through, and it will be done for the payment year that you're in. So how do I score in that? Then they're going to use them, whichever score is the most favorable for you. It's either a patient count or a dollar amount. So of the people that I treat, how many of those were in a risk-based model? So for the dollars, 25% to be a qualified professional, and 20% on the count. So if you're just counting, then there's this thing called a partial qualified professional. And if you've ever read a regulation and then you realize at the end, oh, I don't know what a partial qualified professional is. So I did go back, and it's someone that doesn't quite fit the category of the advanced APM. So you can choose MIPS. So you would at least get some potential of getting some upside on your payment. Okay. Now, if you've met all those criteria, if you're in an advanced APM and you're a qualified professional, then you don't have to participate in MIPS, and you will get an automatic 5% increase in your fee schedule. So, okay. All right. I mentioned earlier CMS. We have approximately 761,000 professionals, and they're estimating 30 to 90. Only 30 to 90 are going to fit in that advanced APM model. So that's about 12%. So they're also saying that the cost for implementation is, they admit it could lead to higher operational expenses, but they believe that the combination of the payment adjustments and the overall gain in efficiency will offset those initial expenditures. And they also believe we're going to have a positive impact on our quality and value of care. And I looked at there's a chart in there by specialty of what's the plus and minus. And sometimes they put the dollars in very big dollars. When I did it per physician, this was their estimate. In 1 year, that first year, internal medicine, you could either lose $1,100 or be up $1,900. If you actually got into the bonus, then you could triple that. So that on the plus side, it's on the plus side. They also mentioned, which I thought was interesting, that they think the hours to do quality should take 6 hours of not an analyst type person and 1 hour of a physician, that the advanced care requirement should take 4 hours, and the CPIA should take 4 hours. And I multiplied this all out. So they're saying, at a high end, that this should take $1,700 in a year, and they weren't considering that, overly burdensome. So just interesting, the impact projection that CMS did on this. So I'm going to stop now and see if Dr. Ashira has any comments that he wants to add before we talk about readiness.
Well, I think, Bobbi, all of this really pertains to the fact that in order for practices to really benefit from this, remember, it is a zero-sum game, and so if there is no preparation well ahead of time, just looking over the eligible programs that are there that your organization or your group can participate in and think that you can make a meaningful impact. It's so important for all of the physician groups to actually go out there and actually read, these rules and so forth, to see what the eligible things are that they can do, because it is going to take time to gear up for that. So there should not be a lot of delay. And I have to emphasize that CMS actually is very interested in hearing about the public comments. I know we stressed that before, but I can't overemphasize that as well.
Okay. I sat down and thought about some things that I would do. We have a poll question.
That's right. We inserted this there. We'll go ahead and ask that to the audience. This will give you a good sense of what they think about all this. How optimistic are you that the April 27th proposed regulations will produce the results that CMS is expecting from MACRA? 5 options. 1, not at all. 2, somewhat. 3, unsure. 4, optimistic. 5, very optimistic. We'll give the audience one more moment to answer this. And some people are asking questions about the slides. We will give those to you after the presentation today. There will be an email with that information. Okay, we'll go ahead and close that poll and share the results. So the results are 20% said not at all, 39% said somewhat, 29% said unsure, 13% said optimistic, and 0% said very optimistic.
And again, remember what they were trying to do is offer multiple pathways for risk and reward, minimize the reporting burdens, streamline multiple programs. So we're not getting rid of, but we're streamlining meaningful use PQRS and this value-based modifier. And then rewarding clinicians for value over volume. So that's what we're responding to. Dr. Ashira, any comments from you about the poll?
No, I think that's what I would have expected from what we're hearing and so forth. So yeah, I think that's about right.
Okay, good. All right. So go on. HFMA, I'm a member of the Healthcare Financial Management Association, and their president, Joseph Pfeiffer, said, well, we are going to see some predictable updates for fee schedules. It's not 100% predictable because it will depend on your performance. So there is an encouragement to get physicians in these new payment models and also to adopt the interoperable electronic health record, which is something that our nation does need to do. He also asked a question, are we encouraging consolidation? And he also made the statement, this is not going to be a cheap or a simple participation agreement. And another reaction, may push independent physicians to the breaking point. I predict more physicians are going to seek employment and let the health system worry about all these measures and having the certified EHR. I just want to practice medicine. So again, Dr. Ashira, any comments on that?
Well, I think that this is the whole apathy, not apathy, but I guess the issue that we're all struggling with as physicians and so forth, that just the rules and regulations are becoming so burdensome and onerous that we feel that we cannot practice medicine. It's more about the business of medicine. But given that, it's so important that we are engaged in this because it is part of our everyday lives. So going forward, I think it's so important for us to be engaged in this process and really understand the rules and regs, because it's not just going to stop, I do not believe, with just CMS regulations and requirements. Many of the other insurance companies are soon going to follow. Medicaid will soon follow as well. So the second grouping there was kind of interesting, where you think, well, there's not a whole lot of pregnancy-related issues, and yet they put nurse midwives in that second group of providers. So I anticipate, because of the majority of the government-funded programs for pregnancy are through Medicaid, that it's not going to stop with just Medicare.
Yeah, great. I didn't even catch that. Yeah, whenever you think Medicare, you don't think nurse midwife, but yes, great. Okay, real quick, I love to do financial impact. So just take your revenue, multiply it times 4%. That's your potential reduction. That's probably not going to happen. So if you had 25 million worth of Medicare revenue, you have a potential negative impact of $1 million. Then you can adjust up from that as you think, where you think your scoring is going to be. You also have to think about what investments do you need to participate in this. And if I'm under alternative payment, advanced alternative payment, and I'm a qualified provider, and I can get 5% increase, should I explore that option? What investments do I need to make to go into that? So those are things you need to be thinking about. And this was my to-do list. I had a deadline to outline a strategy. I had a deadline of Q4 in there. I switched it to Q3, but let's make it somewhere between Q3 and Q4. By Q4, we're almost close to 2017. It's Christmas time, so we want to go Q3. Do I know which track I want? Again, like I said, it isn't like you can pick, but if you could pick, which one would you pick? And what's the impact on my practice? And what do I need to do? What happens if I do nothing? And am I already moving to some value-based modeled? So what's going on? What have we been looking at as a practice, and what have we been doing? As far as with value-based, you may think, okay, yeah, I want to go be an ACO. Good luck. The letter of intent is due May 20th, and your application's due May 25th. For next generation. For MSSP, you could probably make it. I could write a letter by May 31st, and your application is due July 29th. I don't know if I could do the application by July 29th, because you really need to go through the application process and figure out, there's a lot that goes on into deciding you want to be an ACO. But I just put these up here to let you know for Medicare that there's just a lot going on right now, and it's right around the corner. So you may just say, okay, we're going to go in MIPS for 2017, but then in 2018, I want to know, so I'm prepared next year so I can make a letter of intent by May, or and an application that will be applicable in the following years, 2018. Educate and communicate. Provide clinicians with summarized documents. Dr. Oshiro was very kind to say, really read the regs. There's a lot out there. There's a lot of webinars out there. And I think just getting a basic understanding, I think it's important to get a basic understanding, then dig a little bit deeper. And I'm not sure everybody has to dig a little bit deeper, but some people do need dig a little bit deeper. Make time in your current meetings to talk about this. And I think if you stay informed, it'll ease the stress. That's just personal. The professional societies, like I mentioned, CMS, they have done an outstanding job. The family physicians, they have a MACRA-ready program out there that you can and I gave you their websites, and you can just get on. AHA has been good, AMA, very good. Again, and sometimes the way I think, I can't just hear one person explain it to me. I have to hear a couple different people explain it to me, and especially on some of those areas, like, am I going to be an alternative payment model or not? Some of those are a little tricky, and you want to work through a decision tree, and there's just so much good information on all of these websites that and they really are trying to represent the physicians and do the right thing for the physicians and make sure that voices are being heard. I like to talk to other people whenever I'm against, and I have a person in the room that I always ask. Chris is in the room with me. He's our marketing VP here, and I always will go to him and ask, well, how should I show this, or give me some ideas. And I would say go outside of your field, ask people who other industries who have faced this kind of a challenge. What did they do? What ideas can you get from other people? And just put that into your discussion mode. Look inward and know your strengths. Now, you might say, why in the world did this lady put that? That is one of my paintings, by the way. And I have to tell you, I take all these painting classes. I haven't in a while, but I go to the painting classes and I buy everything. If they tell you need 3 paints, I buy 10 paints. And I go to the class and all my stuff is new and I have new paper or whatever. And then I can't do anything. So I know that I think I can paint, but I haven't been in any shows. I can't measure anything with my painting, but I do have fun with it. But you need to look now within your own practice and say, what do you do well? And then look at the data that shows what you do well, and look at measures, and do you have a performance plan in place? Who has accountability for this performance? Making sure that someone has accountability is just key to everything. So, anytime I'm working on a project, I don't like project management. I hate when I get those emails from people, but I know that it's something that someone has to have the accountability to get this done by X date. And this is very true in this case, because it's going to be here and you're not going to have anything done. Look at the quality reports and your meaningful use submission. Who in your organization did this? What can you learn from that person? It's often, we did a lot of interviewing and talking to people who submitted these reports. And I myself have had the joy of submitting some meaningful use reports. And it's interesting just to talk to the people about how they got the data and how it did, and how is that going to impact MIPS. Okay, this is just a quality report. Again, the reference guide, I'm giving you the reference guide that's out there for Medicare. I can't access your reports. You need your own password to get into your reports, but just to let you know. Finally, we've looked at our readiness now. We're ready to go. You have a plan. You know where you can potentially get some penalties, where you need to change. You have data, you have best practices, and you have an adoption methodology. You're going to be able to diffuse this throughout your organization and have outcomes improvements. Outcomes improvements will lead to better quality scores, which will lead then to higher potential bonuses in the MIPS program, and also will lead you to some quality scores that are better in your alternative payment programs, which will be positive for you as well from a financial standpoint. So Dr. Oshiro, do you have any more comments that you want to make about readiness or just in general about this?
I think that it's you've stressed it enough, but I can't overemphasize the need for planning. Planning. You have to get a team organized at your practice, that whoever's been working on meaningful use and reporting requirements, and get them really engaged and start planning as soon as possible. And don't forget to make comments, because unless you actually understand this program, it's going to be very difficult to make meaningful comments that would be favorable as far as changing some of the requirements or so with the program itself. So just a lot of planning, and this year is going to be critical.
Yep, remember my slide 2017, it's getting there fast. Okay.
Very good. That was a tremendous amount of information, Bobbi. Thanks for sharing that, and Dr. Oshiro as well. Before we move to questions, we have 3 items of quick business. First, thank you for showing that slide, Bobbi. Some of you know about this, and I mentioned in the beginning, we have a Healthcare Analytics Summit that will happen September 6th through the 8th. We have 2 giveaways today. I'm going to offer 1 giveaway right now, which is a single registration giveaway. If you're interested in attending September 6th through the 8th, go ahead and fill out this poll right now. There is an expiration to this registration giveaway, which will notify you in the email. So you'll have to act quickly. We'll go ahead and leave that open for another moment. And then we have a second poll question for a team of 3. The opportunity there is for you to bring you and 2 other people. All right, we'll close that poll. Thank you. We'll follow up with the winner there. And then the second poll offers our giveaway team of 3. So if you'll take one more moment there. If you have questions, please ask those in the questions panel. We'll get to that in just a moment. Bobbi, we have probably 40 questions, so we're going to have to sift through those, and you can direct some to Dr. Oshiro as well. Okay, let's close that poll. Last item of business. Our webinars are meant to be very educational. We hope you feel that today. Some of you have asked for a follow-up, and we try and be very educational about our follow-up. If you are interested in having someone from Health Catalyst provide you with a demonstration of any of our solutions, please answer this poll question. We'll leave this up for a few more minutes. Let's go ahead and move on to questions. And I'm going to present those to you, Bobbi, and you can look through those with the help of Dr. Oshiro. We've got a bunch here. So let's start perhaps at the top. My first question to you is, based on what I've read here, who would you direct within an organization? Dr. Oshiro spoke to this briefly. Who would you direct to be the point person to understand this information you just talked through? What kind of profile would you expect for that person?
It has to be somebody who likes digging and likes getting into regulations. And there are people like that. I happen to have someone that works for me. He's a data architect, but he really likes these regulations. And so finding someone, it's interesting that will pop up in your organization sometimes. I would say, talk to people in your organization. Sometimes in small organizations, it's going to be really tough. Many times there are physicians who like doing this type of work. Dr. Oshiro, do you have any comments on that?
Yeah, so this isn't going to be something that you may be used to doing, and particularly with an office practice. So if you have a multi-specialty group, you usually have a billing department. You usually have a office manager per se, but you can't relegate this to just the billing and coding people. You can't just relegate this to the office manager. You may have some nurse care coordinators and nurse managers and so forth that are in your practice as well. Because this is a combination of quality improvement, cost efficiencies, and practice changes that are going to go across your entire practice, it's important that you have a multi-disciplinary team actually working on this. So I would advise for physician practices, no matter how small or large, that you have somebody that knows about the billing and submitting payments, somebody that knows about the practice management, physicians and nurses involved. I think it has to be a group effort.
Okay.
Okay, we have a question about, are hospitals going to be part of MIPS? They are not right now. The providers that practice under a hospital, they will go into MIPS, but in some cases they don't have their own certified EHR. They use the EHR of the facility. So no for hospitals right now. Yes, hospitals will have to submit for providers just like they do on PQRS. So there was another interesting question. Oh, please clarify what cross-cutting is. Cross-cutting means that a measure can apply to a lot of different specialties. It's not just something that's like only for an obstetrician or only for internal medicine. So these are measures, that way they can get a good cross set. They tried to get measures that are specialty specific and a lot of, specialty specific, and then a lot of these measures that could be more what you call more generic. So, will CMS change the measures over time? Oh, heavens, yes, they're going to change. My guess would be, like I said, the last 300 pages or 200 pages of the current regulations, and it's in table format, are actually all the measures. You can pick from 6 of those. And I expect them to change. Some of those will change by the final reg. Probably not a lot, but I expect that over the year they top out on some measures. Whenever we're doing all A on giving aspirin within so many minutes of coming into the emergency room, that measure tops out and they pull that out and replace it with another measure. So
some of the cross-cutting measures that they asked about earlier, Bobbi, you sort of mentioned is care coordination may be one of those. The other thing is access to care, so extended hours and so forth. So those are some cross-cutting measures. So if you can think of office practice and efficiencies that go across specialties, no matter what they are, risk stratification and adjustment issues and so forth may be part of those as well.
Okay, let's see. Do you want to pick another one, Chris?
We have a lot of questions here. It's hard to know which ones to choose.
Yeah, it is. It is hard. Let's see. Do you think MACRA might result in a lot of independent physicians getting consolidated? Or independent docs first to merge? Huge change management issue for the eligible clinicians. I go to an independent physician. My primary care is independent, and I love him. I hope that, and when I grew up, my dad owned a drugstore, small drugstore, and he eventually sold out to Walgreens. But I like independent practice. I like small business. I hope this doesn't happen, but there is some reading on the wall here. Dr. Oshiro, any thoughts on that?
Yeah, I have actually several of my friends are in primary care, and they have solo practices or two-person practices, and they're just waiting to retire. They say that this is a very onerous condition. Some of the other ones that are still a little bit younger are looking for employment models because they say that they cannot practice and do the business side of it. It's just getting too complex for them. So I think that that's a correct assumption. At least that's the way that I'm reading the tea leaves, is that people are not going to be able to practice independently. I think the exceptions are going to be in small rural areas where you have low volume providers and so forth, that they cannot go out of business. They need them in those rural areas and small markets and so forth. So I think that there's going to be exceptions based on the volume issues and stuff, and they're excluded anyway. So there will be some accommodations made for that.
I had made a comment about the dollar amount. The financial impact is tiny, so why should I care? And I believe right now under PQRS, I think CMS said only about 32% of the eligible providers are participating in that program. So again, you could be part of MIPS and just go along with like you're normally doing. You will have to submit requirements, and there's not a penalty. I haven't seen any penalties in there yet. Eventually, just like PQRS, that will happen. Penalties for not participating at all if you didn't turn in any measures. So eventually that, I would say, that will happen. It's not there right now, though. So
here's an interesting question asking why the regulation doesn't address HIPAA or compliance or security.
The regulation says you have to attest to security, that you are doing your best to meet security requirements. So there will be an attestation in there, and I would assume over time that this is one that we will see more regulation on. Again, any comments on that, Dr. Oshiro?
No, that's right. I think that's it is part of it that's incorporated into it, but it's not a major focus of the program.
Yeah. So yeah, they're bringing in the meaningful use and trying to make it not too onerous for people. So so let's see, the 300 measurements, are there up? Not right now. We don't have upper limits, lower limits. Again, 2017 will be the base year. So yes, it will be the performance year, and So what's in 2017? Then they are going to try to get you a report by July of 2018, and that will all have to be. We can't take vacation. We can't have vacation then, but we really want to look at when those reports come out in July of 2018, where we are. They are going to put some reports out in July of 2017 that will be based on history. And again, you probably not that much movement in the measurements. So, and probably what you're reporting now for PQRS, you can, like I said, look at your own PQRS and see what's going on, and then you can go from there. Will PQRS no longer be the standard? Yes, PQRS will no longer be the standard and be integrated into MIPS. Yes, that's the whole point of MIPS. So you'll do PQRS in 2017 and in 2018, then in 2019. Goodbye.
That's right. We probably have time for one more question. Here's one, Dr. Oshiro, that I think is directed towards you. Can you compare and contrast the impact of MIPS on specialty physicians versus primary care physicians? Can you also compare and contrast the impact of APMS on the same? How does MACRA participation relate to bundles?
Yeah, so that's kind of an interesting question, and it's unclear as to what the impact is going to be. So we'll have to see going forward. So that's something that I myself, being a subspecialist, we're going to be impacted on that as well. So I'm going to have to take a look more carefully as to how that's constructed. But it's the overall through the care coordination aspect of it that's what's going to look like as far as getting into our practice. But there are performance measures for individual subspecialties, and so that's going to be an area of intense focus for me personally as well.
Okay, very good. Thank you, Dr. Oshiro. Thank you, Bobbi, for a tremendous webinar with lots of information. I wish we could have gone a little longer. There were still probably 35 questions. And by the way, we have had incredible attendance. We had 1,200 people register for this, and we've had a great turnout today. So thank you for everyone who joined today. Shortly after this webinar, you will receive an email with links to the recording of this webinar, the presentation slides, and the poll question summary results. Also, please look forward to the transcript notification we will send you once it is ready. On behalf of Bobbi Brown, Dr. Brian Oshiro, as well as the rest of us here at Health Catalyst, thank you for joining us today. This webinar is now concluded.
Thanks.
Thank you.